Good afternoon and welcome to our 6th QI Connect session for 2018, which is also the 45th session since we began. QI Connect provides an opportunity for colleagues across health and social care and indeed beyond to learn from international leaders in the fields of improvement, innovation and integration. We've designed these sessions to be as short, accessible and recorded to allow access at a time that suits all you. And I'm now going to pass you over to Jennifer, who will tell you a little bit more about the session and the technology. So good afternoon, Jennifer.
Good afternoon, Simon, and good afternoon to all of our QI Connectors joining us today. I've just got a couple of quick housekeeping slides to get started. If you could please use the chat function that you see on the right-hand side of your screen to communicate, and I'll talk you through this in just a moment. And if you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, then please message the event manager using the chat function or by pressing *0 on your telephone keypad. So these sessions are designed to be a fun, interactive learning experience, and we do really encourage you to use the chat function to share any questions, comments or ideas throughout the talk. Just to note, there will be an opportunity for some Q&A at the end of the session also. And also just to let you know that we will be sharing some hyperlinks within the chat function to any of the resources mentioned by our speaker today. So we did promise that today's session was going to be fun and interactive, and this is the interactive part. We're really keen to find out where you are joining us from today. So if you could please select the annotation tool that you see circled in red on the screen there, to the top left-hand side of your screen. And then click on the arrow icon, again circled in red. And then if you can just click on the map, just let us know where you're going to be joining us from. We know that sometimes there can be a bit of a slight delay from colleagues joining out with the UK. Oh, welcome. Welcome, Alison, Wanda, Akin. Great. Okay, so I'm now going to just hand you back over to Simon, who's going to just tell you a little bit more about our QI Connect series and the organisations and countries that are now joining in.
Well, I'm delighted to say that we now have 799 organisations joining us for QI Connect. So we need one more organisation, and then we'll get into the next century. And we did say that this was going to be fun. So the fun hasn't ended yet. It's competition time, and get your fingers ready on the mouse, because the first person to click on the flag for Peru, country of Peru, will win an exciting prize.
Hi folks, if you just bear with us one moment, just having a slight technical issue. Okay, that's us back on. So competition time is back up and running. Okay. Okay, so we're back on competition. So the first person to click on the flag of Peru. So Akin, close, but we're just watching. Eunice, congratulations, Eunice, and delighted that you've won our competition. And if I had a drum roll, I'd be playing it just now. So drum roll, please. Eunice, you win a much coveted QI Connect mug. So congratulations, and we'll get that sent out to you.
Okay, thank you. Sorry about the technical hitch. That was entirely my fault. Right, so congratulations on that QI Connect mug, a much coveted prize. So let's have a look at all the organisations that have joined us since 2014. I'm not going to read them out. There's just too many, but let's just step back and see just how many people have joined us. And we've got representatives from all of the Scottish National Health Service boards. And I'm delighted to say we have 4 new organisations joining us today. And these are Dumfries and Galloway Royal Infirmary, the North York General Hospital in Toronto, Sustrans Scotland, and the West of Scotland Cancer Network. And of course, we're always delighted that QI Connect reaches our colleges and universities across the world, and we now have 69 linking in. And we have a new university joining us today. We're delighted to welcome the University of British Columbia in Canada. So welcome to all of you, strengthening our Canadian theme. And given our global reach and the challenges that brings in terms of time zones, we record each of our sessions and make these available on the Healthcare Improvement Scotland website. So here's a photo of some of our colleagues in Aotearoa in New Zealand bringing the staff together for a lunchtime session to listen, learn and share. And in addition to, I think we need to go back a slide, in addition to and all of these talks are on the back catalogue on the website. We're also delighted that the QI Connect series is now featured as an approved learning resource within the ISQA Fellowship Programme. And we're delighted to confirm our continued partnership with Q, which is an initiative being delivered by the Health Foundation and supported and co-funded by NHS Improvement. Okay, so there's a big shout out to the QI Connect team today. We have a guest chair today, which is myself, and I'm Simon Watson. And some of you may know I work in Edinburgh as the Chief Quality Officer for NHS Lothian. You've already heard from Jennifer and myself, but a special mention also to Michelle, Jessica, Carmen and Alex, and especially to our absent friend and colleague, the Chair of QI Connect, Dr. Brian Robson, who unfortunately couldn't be with us today. And Brian, we miss you and hope you'll be back in the studio with us very soon. As the people familiar to this format know, we also have a guest questioner, and this is Jacqueline Walsh, who's a Quality Improvement Advisor in Women's and Children's Services from NHS Ayrshire and Arran, just down the road. So welcome, Jacqueline. And please remember, as part of the sharing, to remember to tweet as you learn using the hashtag HisQIConnect, and also to follow us on @HisQIConnect, as shown on this slide here. And without further ado, to the main event. It is a real, genuine pleasure to introduce Dr. Danielle Martin, who's the Vice President for Medical Affairs and Health Systems Solutions and a Senior Fellow at the WCH Institute for Health Systems Solutions and Virtual Care in Canada. There's an awful lot we could say about Danielle Martin, but I'd highlight that she is a leader in the debate over the future of Canada's healthcare system as well as abroad. In 2017, she was asked by the Federal Minister of Health to participate in a national review of 8 major federally funded pan-Canadian health organisations to make recommendations in the future. The achievements on her CV are really too long to highlight in detail, but she holds a Master's in Public Health Policy. She is a national best-selling author. She is a familiar face in the media talking about important issues in healthcare. I had the pleasure of being in Canada 4 years ago, and that was where I first encountered Dr. Martin's work. And I'm particularly pleased that as the fill-in speaker today, it's Danielle Martin who's in the speaker's chair. So without further ado, welcome very much, Danielle Martin, and we look forward to your talk. And thank you for being with us.
Thank you so much, Simon, and thanks for inviting me to participate today. I'm really excited to be able to spend this time together with you. I'm going to be drawing in my presentation heavily on a special series that The Lancet just published a couple of months ago about Canada. So for those of you who are bitten by the bug of the Canadian healthcare system over the course of our discussions today, I wanted to alert you to the existence of this special issue on the Canadian healthcare system, which you can access on the Lancet website. But I want to begin by talking about something that is very near and dear to my heart, which is the history of the Canadian healthcare system. And you'll see here on the left-hand side of my opening slide a photograph of my grandfather. This man, whose name was Jacques Chilton, was a an immigrant to Canada with his wife and 2 young daughters and parents-in-law in the early 1950s in Canada. And as my mother tells the story, her family boarded a big ship in Cairo, Egypt, in the middle of December and arrived in Halifax, Nova Scotia. For those of you who know anything about Canadian winters, you can probably imagine what it's like to arrive in Halifax, Nova Scotia in December from Cairo. And she remembers, because she was a small girl, that the snowbanks were like mountains towering over her head. And like so many Canadians who have immigrated to this country from countries all over the world, they had come to build a better life for themselves. And the primary burden of that journey rested on the shoulders of this man, Jacques, who, as you can see, was a very handsome and a very serious fellow, very educated, spoke 7 languages, and they started their new life in Canada in a small apartment in downtown Montreal, as is so often the immigrant story, in pretty cramped quarters with not great employment, but great hopes for the future. And those hopes were cut short when only just a year after their arrival in Canada, at the age of 42, he suffered a massive heart attack and was hospitalized, as was done in those days, for over 8 weeks. And you can imagine the stress of not being able to access, not being able to work and therefore support his family, not to mention the physical stress that he was under. But most importantly for them, it became clear, were the costs. The cost of the hospital stay, the cost of the doctor's visits that followed, the cost of the medications, which put them into debt to family members and essentially financially ruined the family. Over the course of the coming years, his health would continue to deteriorate, and by the time he died, a few years later, at the age of 54, the family was in a financial state that they would never certainly recover from in that generation. And the irony of the story is that the year of his death was the year 1966, which was the same year that the federal government in Canada first moved to create universal health coverage in this country, the system that we now call Canadian Medicare. And so I ask in the opening of the book, which Simon mentioned, and I've now asked this question to audiences across the country in the last 18 months, how different would life have been for my grandparents and for my mother, who grew up in these very difficult circumstances, if universal health coverage had existed just a decade earlier when they first arrived in Canada? And the answer, of course, is it would have changed everything. And yet that fight to institute universal health care in Canada was a fight, as it so often is, and and its protection remains a battle even to this day here in Canada, as I know it is in the NHS and all over the world. We are always trying to hold on to the gains that we make when we try to reduce gaps and increase equity in health systems. And to give you a sense of what that battle was like in the early days in Canada, I've included 2 other photographs on the slide. On the far right-hand side is Tommy Douglas, who was the Canadian Premier who first brought in universal health insurance in the province of Saskatchewan, and who went on to help participate in its expansion across the country. And in the middle is a photo of the doctors' strike in 1962 in Saskatchewan, which was the reaction of the physicians of the day when Medicare was brought into place. And so we have a long history of mistrust between organized medicine and government when it comes to the running of our healthcare system that stems all the way back to the very beginning. And yet Medicare remains in Canada by far the most popular and the most culturally defining social program of the nation. So the story that I share with you about my own family is a story that is shared by families across the country, people who remember what it was like before we had universal public health care in this country, and people will continue to point to Medicare as the defining social program of the nation, so much so that Tommy Douglas was voted in a Canadian Broadcasting Corporation, CBC, competition a number of years ago by the general population, the greatest Canadian of all time. And so politicians know that one touches Medicare at their peril in this country, and yet even so, there is much work still to be done. So in that context then, what is this program that we have so much pride in Canada? It is fundamentally actually not a national health care system. It does not resemble the NHS. It is a system that is essentially 13 interlocking provincial and territorial health insurance plans, and then a number of additional federally run insurance plans that cover populations designated under federal responsibility, which includes Indigenous peoples, and I'm going to speak a little bit about Indigenous health later. And so we actually have, people are fond of saying we don't really have a Canadian healthcare system. We have 13 plus healthcare systems across the country. That's not entirely true either, because there is an oversight and a very important national role for our federal government, as well as the national imagination, if you will, that holds our healthcare systems together in the form of that deep social contract that our population continues to recommit to. But in the day-to-day, Canadian provinces, which are our subnational jurisdictions, run the healthcare systems. And what links them together is a single piece of legislation that determines under what conditions Canadian provinces and territories will receive federal funding to pay for those healthcare systems. And there are a few very simple rules that are articulated in an iconic piece of legislation known as the Canada Health Act, which essentially consists of the federal government saying to the provinces, we will give you contributions towards the financing of your health systems across the country, and in exchange, you as provinces and territories have to meet some very basic conditions, and that includes the very important condition of a single payer in each province and territory for all medically necessary physician and hospital services. And that really is what creates some semblance of a national system across the country, even though the systems are run by the provinces and territories, is that basic floor below which no province may sink if they want to continue to receive federal contributions, which, although federal contributions are only in the range of about 20% of the financing, continue to be very important to the provinces. A final word on the relationship between provinces and territories and the medical profession, because I spoke about the pain of a new idea, and the pain of new ideas in Canadian healthcare has long been linked to the dance between doctors and governments that takes place in the day-to-day running of healthcare services, is to say that ever since those early days in Saskatchewan, the agreement that was reached between organized medicine and government at the time was that physicians would be publicly paid, and indeed we do not permit private payment or private insurance in Canada for those services that are covered by Medicare. Physicians would be publicly paid for the delivery of their services, but they would remain independent entrepreneurs, independent contractors billing the state for their services, or billing state insurance plans, government insurance plans for their services, but not employed by government, not employed by a health service of any kind, and primarily still to this day paid on fee-for-service. And so there is an interesting dynamic where the payer controls the purse strings, and yet the fees, of course, are negotiated between physician, organized medicine, and governments, and the practice of medicine is entirely both self-regulated and self-governed, self-directed by independent practitioners. It means that there is a constant dance between doctors and governments in trying to figure out how we achieve health system reform. And it will become clear, I think, why that's so important in the Canadian context when we speak about the challenges that we face today and how we're trying to address them. So I don't expect anybody to try to digest the chart on my fourth slide, which speaks to outcomes, but this is a snapshot of, many of you will be familiar with the Lancet paper on the Health Access and Quality Index that came out just last year, I guess. And as you can see, if you take the time to digest a little bit these various different rankings, you know, this is probably the most, I believe, the most comprehensive analysis of international health system rankings ever published. And this index places Canada 17th out of the 195 countries and territories that were reviewed. And so I always say to my residents, although this is a gross oversimplification, when I'm teaching healthcare policy, on health outcomes, I would rank Canada a solid B. We are not the best healthcare system in the world. Remember that most of these diseases that are being looked at here are looking at amenable deaths. In other words, you know, deaths that could be prevented if healthcare systems are functioning well and providing care in a timely and high quality and consistent manner. But what saves us in some ways in Canada is the fact that we also continue, at least to some degree, to invest in the social determinants of health. We have a very long life expectancy of 82 years at birth, with exceptions of some populations, which I'll speak about later. And overall in Canada, if you're admitted to the hospital or you have an acute healthcare problem, you will be well treated. You will get world-class care. And of course, in Canada, what matters most always to Canadians is how we rank vis-a-vis the United States. I'm sure that it's no mystery to anyone on this call that we share a border with the largest, most expensive, most profit-driven, and most inequitable healthcare system in the developed world. And so Canadians are very fond of ensuring that we always check to see that we rank ahead of our friends south of the border on these rankings. But of course, that's never good enough and shouldn't be good enough. And we have much to learn from interactions with our colleagues more broadly and internationally. I want to spend a little bit of time on challenges here before I launch into the discussion about innovation and quality, which I know is what drives these QI Connect sessions primarily, because in order to understand where we're focusing our quality improvement efforts and health system reform efforts in Canada, you need to know what the big problems are. And the team that I worked with on this Lancet series laid out the 3 big existential challenges that face the Canadian health system, and I'm sure they will be familiar to all of you in some way, shape, or form. The first relates to wait times for elective care. And there is no doubt that although one can quibble with the methodology that's used for a variety of different comparative international studies on this, as a family doctor working in the Canadian healthcare system, I can tell you wait times are too long in Canada for many forms of elective care. We see people waiting longer than I think is reasonable for many forms of elective surgery or planned surgery, for advanced diagnostics in some cases, such as MRI scanning, for outpatient specialty appointments. I feel the need to stress here again that this is all in the context of when people are in trouble, they are treated rapidly in our system. I have never had an instance where a patient was in trouble where they weren't treated immediately. So there is no, the myths that get propagated, you know, specifically in the American media, often about, you know, people sort of dying on wait lists are patently untrue. Of course, every health system has its cracks and its failures, but by and large, when people are in serious trouble in the Canadian healthcare system, they're served rapidly and they're served well. That does not diminish the quality of life issues associated with waiting too long for planned or elective care. And I give some examples in the slides, but you know, Canadians, although they're quite satisfied, for example, with their interactions with their primary care physicians, and generally feel like they're seen quickly enough when they really need to be, the number of folks who wait longer than 48 hours when they call their family physician's office with an issue that they perceive to be of timely importance is too low. and lower than our international comparators, and the list goes on. So this is a very important challenge for several reasons. The first is that it's a political challenge in that the support that Canadians have, I believe, for universal public health care extends, of course, only so long as they believe the system will serve them well. And we have an obligation, those of us who work as leaders in the system, to make sure that we continue to deliver for people, that they have the confidence and the trust, that we not rupture that public trust, that the system will be there for them in order to ensure that we can continue to sustain political support for a universal single-payer system. Second important existential challenge I want to highlight relates to those services that are not covered by Medicare, because you may recall that I said that the requirement in Canada is that our provinces and territories cover with a single-payer system medically necessary physician and hospital services. Well, that might have been fine in my grandfather's time, although probably it wouldn't have even been fine then, but it certainly isn't adequate today when you think about the ways in which, of course, the disease burden is shifting in all developed countries with an aging population and a rise of chronic disease. Doctors and hospitals are not the place where we're going to get a high quality of life for that growing population of seniors with complex chronic illnesses. Add to that the great irony that prescription medications were excluded from Canadian Medicare, such that when a person is admitted to the hospital in this country, if they require, IV medications, if they require chemotherapy, if they require, whatever expensive drug you can imagine, it will be given to them in hospital with no charge at the point of care. But the instant they're discharged on the sidewalk with a prescription in their hand, that person is on their own to figure out how they're going to pay for their prescriptions. And this is an accident of history. It has to do with the way that our programs were set up in the 1950s and 60s in Canada. And we now are the only country in the developed world with a universal health system that doesn't include prescription drugs. And so there is a huge debate going on in the Canadian healthcare system today about how will we get to universal pharmacare and the inclusion of prescription medicines in our public plans. Until that day, we have private insurance that has risen to meet the challenge mostly through people's employment. And so many Canadians, in fact, most Canadians have private coverage through their employer of one form or another, but many are also uninsured and underinsured for prescription medications. Third existential challenge I want to speak about is the unacceptable health disparities that exist for our Indigenous peoples in this country. Canada is a country that has very high rates of immigration and is the product of the formation of the conglomeration, if you will, of British colonies in the 1800s. But there are people who have inhabited these lands for thousands of years, and Indigenous Canadians have suffered horrendous treatment at the hands of colonial Canadian governments for many generations, something that we are now grappling with as a country in the wake, in particular, of a very important Truth and Reconciliation Commission that took place not long ago in this country. And in addition to many other social issues that face Indigenous peoples in this country as a direct result of the policies of the Canadian governments of the day and even still to some degree today, we also see horrendous disparities when it comes to Indigenous health. And so just to give you a sense, you see here on this slide the differences in life expectancy and infant mortality between our Indigenous peoples and settler populations, or at least the average. And so this is an area where I would say it's fair to say that Canada is waking up as a country to the critical importance of these issues and has been waking up. And those of you who follow the news may have seen that our Prime Minister, Justin Trudeau, spoke about the about Indigenous relations and Indigenous issues at the United Nations not long ago. So certainly something that is high on the awareness radar amongst settler Canadians in a way that it was not even just a generation ago, sadly. I want to conclude this portion of my conversation by telling you about a woman I call Susan, who's a 75-year-old widow who lives in a small community in rural Saskatchewan, which is in the center of our enormous country. Susan is one of those folks who you will all recognize, who's sort of accumulated a diagnosis per decade over the course of her very happy and productive and active life. She developed diabetes in her 50s and lung disease in her 60s from having smoked in her youth, a heart attack at the age of 72, followed by bypass surgery, and to top the cake, osteoporosis on her 74th birthday. And like so many Canadian seniors, Susan now takes 8 different medications, she sees 3 different specialists, and she needs to be on top of all kinds of elements of her own care. But she is functioning, she never misses her bridge game on Tuesday afternoons, and she's doing quite well. One winter she develops a cold, and she calls her family physician's office to make an appointment because she's actually feeling quite unwell, but he's away. He's gone to Florida for a couple of weeks, and the message on his answering machine says, because he's a solo practice GP without a team to back him up, the message on the machine says, if you're really sick, go to the Emerge, otherwise, call when I'm back in 2 weeks. Well, Susan doesn't want to bother anybody, so she stays home. And 5 days later, when she's really quite unwell, she ends up going by ambulance to the emergency department. And she's actually admitted to hospital because by that point, she's quite dehydrated. While she's in the hospital, she has a difficult time sleeping, and so she's prescribed a sleeping pill by a helpful doctor on call. And when she gets confused and wakes up groggy in the middle of the night and gets out of bed to pee, you all know what happens. She falls and breaks her hip. 2 days later, she has surgery to fix her hip, but post-operatively, her blood pressure bottoms out, and so the doctor stops her blood pressure medications. And through a series of confusions, she's discharged with a prescription that doesn't include those medications on them, and so she thinks she's supposed to stop taking them, stops taking the blood pressure pills. The family physician doesn't receive any communication about her admission for several weeks, and probably the fact that she doesn't restart the blood pressure pills contributes to her second heart attack. The ensuing months consist of a series of hospital admissions and several weeks in the intensive care unit before Susan eventually passes away. I suspect that you all know Susan's in your own healthcare system, and we all know that her care trajectory does not have to be this way. The fact that we happen to have coverage for her doctor and hospital visits does not help Susan in the navigation of what is an extremely complex system with poor communication between its component parts. If her family physician or a nurse practitioner or another member of his team had been available when she first got sick, maybe she wouldn't have ended up in the Emerge at all. If the information had been better communicated across the different parts of the system as she moved from here to there, maybe the medication error wouldn't have occurred. If she had been asked what her care goals were, maybe she wouldn't have spent the final 18 months of her life going in and out of the emergency department and in and out of the inpatient bed. And if she had been offered the option to die at home, all of this could have been a very different story. Well, the good news about this is that, as you all know well, fragmented care like this is something that we can fix, and it doesn't require us to spend a whole lot more money. So much of what we know needs to happen in this country with respect to the reorganization of healthcare delivery would actually cost us less than Susan's story cost, not to mention giving her a better quality of life. But what is required is a reorganization of the way that we deliver services and the critical full participation of my own profession, physicians, in that reorganization as co-creators of a system in which they're very important players. And because of the tensions that exist, at times at least, between medicine and organized medicine and governments, that can be very difficult to orchestrate. The result of that is that we have tremendous innovations taking place in the Canadian healthcare system all over the country to try to improve care for people like Susan. I'm happy to share some examples with you from my own organization and beyond. I've been traveling across Canada for the last 18 months, learning about many of the incredible pilot projects that have been taking place to reduce unnecessary and inappropriate care as part of the movement of choosing wisely that we see building, a slow medicine movement building in North America and, of course, across Europe and well beyond. The use of technology, not just in ways that are cute or interesting to look at, but in ways that actually allow people to be more engaged agents in their own care and their own decision-making, and to improve monitoring of chronic disease in the home so that we aren't sending people to the emergency department for everything, because our system truly was built in a way that results in all roads leading to the emerge. New models of care in my own organization that include outpatient resources to support primary care, so that if a family physician calls with a question about a patient, rather than referring that person on to see a specialist, they can get an answer immediately on the phone and take care of the management of that person sitting in front of them, or e-consultations that serve a very similar function, and the list goes on. And if we think back to those three big challenges, wait times, access to services outside the Medicare basket, and improvement primarily but not exclusively through the social determinants of health for Indigenous peoples, all of those things require that kind of reorganization of resources. And the pilot projects are happening all over the country. But the problem in Canada, therefore, is not about innovation. The problem is about the spread and scale of that innovation, and this will be where we draw to a close for some interaction and discussion, because actually the kinds of innovations that we see happening are proof positive that it's not as though we don't know how to do better care. The problem is that we do not seem to have adequately identified the levers for scaling up these successful models across the entirety of the Canadian healthcare system. And knowing what you know now about the deep decentralization of our system, both to the provinces and territories in terms of the financing and oversight of the systems, all the way down to the level of the interactions between the physicians who work in the system and other players who are employed in the system, you can begin to imagine how it is tricky to move projects that are successful in one community or one region or one province across the country, with the result that people's access to care does become determined by their postal code, not because they don't have universal coverage, but because the variation in the delivery of services is so great. I want to share with you one example of that by showing you a video that was on our local TV news station just a few weeks ago when we launched at my own organization, Women's College Hospital, our same-day knee replacement surgery program. This program is intended, in one of the ways that we know that wait times for hip and knee replacements, which are quite long in some parts of the country, one of the backlogs, or the choke points, if you will, in access to elective surgery is hospital beds, because surgeries end up being canceled when there isn't a bed available to put that patient into. So it's not always about operating room time or access to surgeons or nurses. So instead what we've done is this same-day knee replacement, and I'm going to show you a brief video about that now. Someone else is controlling.
For knee or hip surgery, and as our population ages, those wait lists are getting longer. Now a Toronto hospital is trying a new approach, offering same-day joint replacement surgery, and the results are remarkable. CTV's medical specialist Avis Favreau has the exclusive detail.
Each year, some 120,000 Canadians need joint replacements, like 56-year-old Greg Nemeth, who's about to get a new knee, ending years of pain from arthritis.
Enough was enough. Couldn't tolerate it. My knee was in a bent position all the time.
Doctors at Women's College Hospital are pushing the boundaries of this common procedure, offering him what some call drive-through joint replacement, hospital to home in 6 hours or less.
we've had no complications so far. I'm picking people who want to go home, want to get back to work. They're a motivated population.
His surgery began just after 8 a.m. The first difference, he's awake during the operation. Awake as doctors remove Greg's old knee and insert the implant. That's because they use short-acting anesthetic and a spinal block to stop sensations, but to allow patients to start moving shortly afterwards. An hour later, the surgery is over.
That's great. You're above 90 already.
And just 2 hours later, Greg is up walking.
I can feel my knee straightening.
Climbing stairs.
Yippee.
By mid-afternoon, he's home, connected to his medical team via special app.
Hi, Dan.
Where a nurse or doctor will monitor his nausea, pain, and medications.
What would you say your pain is at now, Greg?
I have a little bit of pain, but not a lot, and happy to be home.
We have actually been able to not only manage symptoms, but also manage complications. People are able to actually just very quickly ask me a question that otherwise would kind of be bringing them to the emergency departments.
Some doctors think that over the next decade, up to half of all hip and knee replacements will be done with same-day surgery in a bid to ramp up capacity and keep down costs.
I think we are going to prove to everyone that with the right approach, this is doable.
I have no issues with it. So, you know, I do it again if my left knee needed it.
Hoping to be on a fast track to recovery.
There we go.
Ava Stavro, CTV News, Toronto.
Okay, we are back on to that extra interlude of music there. So Simon, back over to you.
So, sorry, Simon, may I just wrap up for 1 sec?
Sure.
Yep.
Yes.
No, okay, great. So I just regarding the same-day knee replacement, I think that you can all appreciate how much work is involved in trying to put a program like that together, but the shame will be if it only ever stays at Women's College Hospital, knowing the need for surgeries like this to take place across the country. And I think that the adoption of ideas like this have always been an uphill battle. I entitled this presentation, "The Pain of a New Idea," which is it comes from a quote from William Osler back in an essay that he wrote in 1906, in which he said, and I quote, "The pain of a new idea is one of the greatest pains to human nature. It is, as people say, so upsetting. It makes you think that after all, your favorite notions may be wrong, your firmest beliefs ill-founded." And I do think that all those of us who are in the quality improvement movement have to grapple with that pain, the pain of these new ideas that require people to think completely differently. But I'm reminded and I'm given hope by the fact that we've always been able to overcome the pain of new ideas in the Canadian healthcare system, most especially the new idea that was Medicare in the first place, something which I think Canadians rightly continue to be proud of and which we need to continue to build upon in order to have the system be worthy of the immense pride we have in it.
Danielle, thank you so much for that. That was a really, really interesting presentation, and you probably didn't have a chance to watch the chat, but there was a lot of very positive comment and interesting discussion around that. So questions are coming in, and I'm going to encourage people on the WebEx to start submitting some of the other questions that they have, but we've already got quite a few. And the first one I'd like to put to you is coming from our guest questioner, who is Jacqueline Welsh from Ayrshire and Arran. So over to you, Jacqueline. Hey, Jacqueline, are you there? Hello?
Hi, Jacqueline. You're maybe on mute just now. Okay, so while we just...
we'll get Jacqueline in a second. So we'll try and sort out the technical gremlin with Jacqueline's question in a minute or so. Danielle, I'd like to put a question to you that's come in from Karen Bell. So I think this relates to your funding model across Canada, and you mentioned I'll call it an anomaly around not having prescriptions covered in your plans. And we're assuming that part of the recent innovation has been therapies that were delivered in hospital, for example, chemotherapy, now being delivered in the community instead to bring care close to the home. That's something we've seen. Is that something you can just get around in your funding model, or is that one of the inhibitors to spreading an idea like that? Would you just comment on that for us?
It's an excellent question, and the answer is it is part of one of the inhibitors. We, of course, are seeing the rise of outpatient chemotherapy and, the medical management through prescription medications of problems that used to be managed surgically or in the inpatient environment. And those technological innovations come to Canada as they come elsewhere in the world, but then we have to figure out how patients are going to pay for them. And so we know it is not uncommon in the multiple sclerosis clinic or the HIV clinic of a large urban environment to have full-time employees whose job it is to try to figure out how to get patients their medicines through whatever combination of private coverage that they might or might not have through their employer, or public sort of safety net plans that exist, or compassionate access through a pharmaceutical company. And so there's a lot of churn or friction energy lost in trying to ensure that people who need access to outpatient therapies can get them in the Canadian context.
Okay, thank you very much. I'm just going to, through sign language, I'm just going to check, is Jacqueline available to ask a question? Because we've got others we can ask.
Yes, I am, Simon.
Hi, Jacqueline. Nice to hear you. Go ahead.
Hi, good afternoon. Good morning, Danielle. Danielle, my question to you is...
Can you speak up, Jacqueline? You're a little bit quiet.
Okay, hang on. Hello, is that any better?
That's brilliant.
Okay, hi. Hi, good morning, Danielle. My question is around transitional care in the maternity neonatal setting. Within the Ayrshire maternity unit, we have inpatient rooms, and what we're planning to do is refurbish some of the family rooms in the maternity inpatient ward to accommodate neonatal babies who are almost ready for discharge. This would then free up the neonatal rooms within the neonatal unit for babies that require a higher level of care. Do you have any similar examples in the Canadian setting that, you could pass on any helpful hits or, any tips for us?
So I don't know the specific, thank you for your question, Jacqueline. So I don't know specifically about the exact model that you have asked about, but I do know that there's an award-winning program at Mount Sinai Hospital in Toronto, which is just across the street from us, in which very preterm and sick babies in the NICU, essentially the parents are taking care of these babies. So there's a big shift and a focus away from nurses and other staff delivering care to the babies, and instead a big focus on nurses and other staff educating the parents on how to take care of their own infants themselves. And the satisfaction rates on the parent side as well as the staff side have been incredibly high. And I'd be happy to send a link to the organizers in order to share a little bit more about that program, because I suspect that there would be learnings and interesting lessons to share across the ocean on that.
Yeah, that would be terrific, thanks. We've actually embarked on a program where we're teaching the parents how to look after the babies. The staff have been working quite closely with them to make sure that they know how to tube feed them, that they know how to record their fluid charts. So we're getting the parents ready for looking after the babies, but we were just wondering about the transitional care as in doing it in a different setting. But your link would be really, really welcome. Thank you.
Great.
That's great. Jacqueline, thank you, and thank you for the answer, Danielle. It's really helpful to a lot of people, I think. So, Danielle, just to keep you on your toes, we'll change track a little bit. We've had a question in from Paul Hogg at the Golden Jubilee National Hospital, and this is around risk aversion. So I guess all health systems in the developed world particularly have risk aversion levels within their culture that will be driven by different things, litigation perhaps in some, regulation in others, media in most, I would imagine. Based on your knowledge not only of your own health system but perhaps others nearby in Europe and the developed world, do you have a sense that risk aversion is a particular issue for Canada in terms of innovation and spread of new ideas?
It is absolutely an issue for us, and in the Canadian context, it's not particularly driven by fear of litigation. It is more, I think, driven, and I've spoken on this in the past, that in Canada, I suspect this is true of other places, we don't just have a fear of risk because people could get hurt, although that's, you know, important to consider when you're in our business. We have a fear of risk because we have a fear of failure, and particularly in the publicly funded context, there is a fear of, you know, governments being humiliated because money was spent on something that ended up not working. And so we have yet to break through, I think, in the Canadian political discourse around what it means to innovate and experiment, and how we give permission to healthcare teams that are trying new stuff to try new stuff, understanding that it may not work. And so the result of that is that when programs don't work, because of course there are always programs that don't work, or, you know, don't represent a significant improvement over what preceded them, or don't save money, or whatever the, you know, the target issue was, we either shut them down quietly and don't say anything about it, and therefore the learning is lost. Or even worse, and this happens, you know, not infrequently in the Canadian system, we just keep running the programs because, and we try to find a metric of success that will make it appear as though the program was successful, because the concern is otherwise the minister gets, you know, brought up in question period. How is it that your government, you know, spent whatever, X million dollars on a program, and, you know, it was fun. These things get framed as boondoggles instead of what they are, which is innovations with full knowledge that not every innovation is going to lead to improvement. And so I think that one of the things that health system leaders can do around that is to be explicit in our communication across the system and with the public when it is that we're trying something new, and be prepared to talk about not everything new always works.
No, that's a really excellent point. There's some nice articles on the NESTA, the National Endowment for Science, Technology and the Arts, written by Jeff Mulligan, who used to run the Downing Street Policy Unit in the last decade, all about the public sector's struggle with adopting innovation that builds on a lot of the themes you just mentioned. So we may share that afterwards as well, because a lot of what you said resonated with that. So if I can, again, just change tack a little bit. When you were describing the evolution of Canada's modern healthcare system, there was huge resonance in my mind, and I'm sure many others, with the evolution of the National Health Service in Britain in the late 1940s. In particular, some of the reactions from the medical profession. So do you think that, do you look across the Atlantic, and admittedly we've effectively got 4 national health systems in the UK now, but do you look across the Atlantic at the national health systems that you see in Britain and see things that you feel Canada should be adopting? And if that's not happening, could you talk a little bit about where the resistance might come from? Is it politics or professional things or other aspects like that?
Yeah, I mean, what's interesting is to hear how the discourse kind of evolves in the Canadian health system. People will often sort of, I think, oversimplify the issue by saying, well, if we just employed all the doctors, you know, then everything would be fine. But of course, as you've identified, we know from our colleagues, you know, across the various forms of the NHS and beyond, that simply employing your physicians doesn't guarantee anything with respect to physician engagement in health system improvement. And you know, there's no single panacea or single perfect way to engage with physicians or pay physicians that will align everybody in the same direction. What I can say, though, is I think that where we have seen physician or clinical leadership, and it's not just about doctors. I single out doctors both because I am one, and so therefore I feel okay, you know, talking about it, but also because the relationship of physicians to the Canadian system is so different from our colleagues in nursing and other professions. But I think that in systems where physician clinical leadership has been linked to accountability for system measures, and we've seen versions of this, you know, wax and wane in the NHS, not only in Scotland, but I know in England as well, for example. I can't speak to every place, but that is where you start to see what we all really want, which is doctors engaged in helping to solve the system problems. I mean, that's ultimately what we're in it for, and only using money or employment contracts to do that doesn't generally, I think, yield what it is that you're looking for, which is true, deep engagement and participation in solving the issues. And the wait times issue in Canada is a perfect example of this. The solutions to wait times in Canada cannot be that we dump more money into the existing systems. The solutions must relate to centralized intake and referral, e-consultation, telephone consultation, virtual care, earlier discharge to primary care with backup support from specialists, and the list goes on. I mean, all of those things require physicians to want to play. And so we're not going to be able to get to where it is we need to go without physician engagement. And I'm not sure that it's just about employment status. I think that a lot of the trust building that needs to happen is going to happen by helping physicians to actually participate in the difficult planning and execution of these system reforms, rather than leaving the physicians out of it and then having to backpedal to try to justify to them why they need to change their practice.
Okay, Danielle, thank you very much. We've got loads of questions. I'm afraid none of them are easy ones. We've got about a minute and a half left. So I'll ask you a nice easy one. One of the questions that came through was around the remote care models, for which Canada is well known over here in terms of its providing care to remote locations. I was wondering if they might have broader applicability to other hard-to-reach groups, not just hard-to-reach in terms of geography, and whether there'd been any experience of that within Canada. You mentioned about some of the inequalities of access to healthcare. Any thoughts on how those models might be used more broadly?
Yes, and for those who are interested, I would recommend checking out the website of the Ontario Telemedicine Network, which was a global leader early on in the provision of telemedicine to people living in rural and remote communities, but has now expanded its offerings to include e-consultation, so a family physician getting, you know, instead of referring your patient to a specialist, you basically send them an email and they'll respond within 48 hours and answer your question. You can save your patient the heartache of waiting for a specialty appointment. Virtual primary care, being able to access your own family physician rather than sort of a virtual walk-in clinic. Through you know, various sort of telemedicine Skype-like models with people downloading an app on their mobile device, and the list goes on. And I do think that for vulnerable, marginalized, hard-to-reach populations, this is the way of the future, and we may be able to leapfrog over some of the more mothballed models of care delivery straight into the 21st century if we focus on the needs of vulnerable groups instead of those who, you know, may be tech savvy but actually aren't that sick.
Okay, right. Well, Danielle, I've just said, unfortunately, I wish we could continue this for a whole other hour, but unfortunately, that's all the time we have with you. Thank you so much for a really, really interesting talk. Lots of fantastic information, lots of things for people to follow up on, and lots of useful information shared as well. So if you were in a lecture theatre, there'd be about 100 and something people in front of you with all the individuals and groups we have here. But on behalf of all those, I'd really like to thank you for your presentation and the time you've given us today. If you could just hold on for a second, we'll just wrap up the rest of the session. So our next QI Connect session is on the 30th of August, 2018. It's 4 to 5 p.m. UK time. You and all our friends in Canada around the world are, of course, welcome to dial in or watch it at a different time. The speaker is Brené Brown, and that will be, I'm sure, another fascinating event. Just can't have this talk without mentioning yet again the great city of Glasgow, which will be hosting the International Forum of Quality and Safety in Healthcare in March of 2019. And I'll just remind people that the call for speakers is open for a little while longer until the 3rd of July, and the registration opens in August. So please look out for that and join us here in Glasgow. We have an amazing QI Connect lineup for the remainder of the year. You've heard from Danielle Martin today. I'm sure that some of the other speakers later in the year will look at that talk and realize the bar is set very high indeed, but we're absolutely delighted that Danielle and all of these other leaders in health and social care, innovation and the cutting edge of thought are able to join us on this fantastic WebEx series. And don't forget that you can follow us on Twitter at the Twitter address there to stay up to date with what's going on. And I hope many of you can join us along with your friends and colleagues at future sessions. So once again, thank you to Danielle, thank you very much to the team, and look forward to getting us together again in August. Have a good afternoon, everyone.